Welcome to the deep dive. Today, we're tearing through some really dense pharmacology material. Our focus, antifungal drugs, a tough but critical area.
Absolutely. Our goal here is to sort of unpack the complexity. We're going to drill down into the drug classes, how they actually work, those significant adverse effects, and maybe most importantly, the nursing process steps needed to keep patients safe.
Okay, so first things first, we need to understand the opponent, right? Fungal infections or mycoses. These aren't just, annoying things like athlete's foot.
Not always, no. They can become systemic, really life-threatening, especially for certain patients.
And the core challenge, as I understand it, is that fungi are eukaryotes, like our own cells.
Exactly. They share more cellular machinery with us than, say, bacteria do. And that biological similarity makes it incredibly difficult to find drugs that are toxic only to the fungus. That selective toxicity is the goal, but it's tough.
Which explains why the drugs themselves can be pretty harsh.
It does. Fundamentally, we're dealing with two main forms of fungi. Yeasts, those are single-celled. They reproduce by budding. Think baker's yeast, brewer's yeast, same idea.
Okay.
And then you have molds. These are multicellular, forming long, branching filaments we call hyphae.
And the infections they cause, they fall into different categories.
That's right. Four main types. Systemic mycoses are the most serious, deep inside the body, organs, bloodstream.
Right, the really dangerous ones.
Then you have cutaneous, subcutaneous, and superficial infections. These all involve the integumentary system, skin, hair, nails, usually caused by dermatophytes.
Got it. So given that range, who are the patients most at risk? The ones likely needing these aggressive therapies?
Well, the list is unfortunately quite long. Think organ transplant recipients on immunosuppressants, cancer patients getting chemo, patients with AIDS, anyone with a compromised immune system.
Makes sense.
But it's also patients on broad-spectrum antibiotics or certain cancer drugs or even corticosteroids. They're vulnerable to Candida albicans overgrowth.
Leading to thrush or yeast infections.
Precisely. The antibiotics wipe out the competing bacteria, and the fungus just takes over that space.
Okay, that really sets the stage for the drug challenge. If we know we need something toxic enough to kill these eukaryotic cells, how do we actually achieve that? How are these drugs classified?
We generally group them by how they attack the fungal cell, think membrane disruption, cell wall inhibition, or interfering with its DNA. Four main mechanisms.
Let's start with the heavy hitters, the polyenes. Amphotericin B and nystatin. Heard amphotericin B called amphoterrible.
Ha, yes. That nickname exists for a reason. Its toxicity is directly tied to its mechanism. Polyenes target ergosterol.
Ergosterol.
Yeah.
That's the main sterol in the fungal membrane, right? Different from our cholesterol, but similar.
Similar enough, yes. The polyene binds to ergosterol and essentially punches a hole, forms a channel in the fungal membrane.
Like opening a drain.
Exactly like that. And once that channel's open, vital intracellular ions, potassium, magnesium just leak right out. Metabolism crashes, cell dies.
Okay, but if it's similar to our cholesterol.
That's the problem. While it prefers ergosterol, it can interact with human cholesterol in our cell membranes. That leads to widespread disruption, especially hitting the kidneys hard. Explains the fever, chills, renal toxicity.
Okay, that connects the dots. So let's pivot to the azoles then. Like fluconazole, voriconazole, if polyenes attack the membrane directly, how do azoles do it? Usually less immediately toxic.
Azoles are more indirect. They don't bind to the finished ergosterol. Instead, they inhibit the fungal cytochrome P450 enzymes that the fungus needs to make ergosterol in the first place.
So they stop the production line.
Right. No ergosterol means a faulty, leaky cell membrane. Similar end result, leaky membrane, cell death, but achieved by blocking synthesis.
Okay, that sounds potentially safer for the patient, but you mentioned P450 enzymes. That rings alarm bells for drug interactions, doesn't it?
Huge potential for drug interactions. We definitely need to come back to that P450 conflict. It's a major issue with azoles.
Right. But before we do, what about the echinocandins, like caspofungin? You mentioned targeting the cell wall.
Yes, and this is where we see better selective toxicity. Echinocandins block the synthesis of glucans.
Glucans.
Glucans are vital components of the fungal cell wall, and here's the key. Human cells do not have a cell wall.
So it's a target unique to the fungus.
Exactly. Highly selective, very effective at causing fungal cell death without that same collateral damage.
Fascinating. And the last main class, flucytosine, the antimetabolite. This one sounds really clever.
It is quite elegant, biologically speaking. Flucytosine, or 5-FC, is actually a prodrug. It's harmless initially.
Okay.
It only becomes active when it encounters an enzyme called cytosine deaminase, and that enzyme is found only in fungal cells, not human cells.
So the fungus activates its own poison.
Pretty much. The cytosine deaminase converts 5-FC into 5-fluorosyl, or 5-FU, and 5-FU then messes with fungal DNA synthesis, stopping growth and reproduction. Very targeted.
Wow. Okay, and we should probably just quickly mention there are others like grisofulvin, which hits mitosis, and terbinafine, kind of similar to azoles.
Yeah.
But those four polyenes, azolses, echinocandins, antimetabolites are the main pillars for systemic infections.
Generally, yes. Those are the core classes we focus on for serious fungal disease.
Okay, so knowing the how, let's talk specifics. The individual drugs, their uses, and importantly, their risks. We have to start with amphotericin B again. Drug of choice for severe systemic stuff like aspergillosis, cryptococcosis.
Yeah.
But that toxicity.
It's the central challenge with Ampho B. Clinicians basically have to expect severe side effects. We're talking fever, chills, low blood pressure, muscle pain, rapid heart rate, and the really big one is kidney damage, renal toxicity. Pretreatment is almost always necessary.
Meaning you give the patient other drugs before the amphotericin, like anti-nausea meds, antihistamine.
Antiemetics, antihistamines, antipyretics like acetaminophen, sometimes even corticosteroids, all given beforehand to try and minimize those infusion reactions, which are often cytokine-mediated. We also slow the infusion way down, sometimes over 2 to 6 hours, and the lipid formulations like Embisome are a huge help.
How do those work?
They essentially package the amphotericin B inside lipid structures. This helps target the drug to the infection site and shields the rest of the body, especially the kidneys, from the worst of the toxicity. They are much more expensive, though.
Right, a trade-off. Now, let's contrast that with fluconazole, a common azole.
Fluconazole is a real workhorse, particularly for Candida infections. A big advantage is its excellent oral bioavailability.
Meaning the pill works almost as well as the IV.
Pretty much. That's why a single oral dose can often treat vaginal candidiasis. It does have a long half-life, though, maybe 20 to 50 hours.
You need to be careful with kidney or liver problems.
Definitely. Dose adjustments might be needed because the drug will hang around longer if those organs aren't clearing it properly. Generally, though, a better side effect profile than Ampho B.
Okay. What about another azole, voriconazole, used for invasive aspergillosis, other severe infections? Are there unique warnings there?
Yes. Voriconazole has some very specific critical cautions. First, absolutely contraindicated in pregnancy. Known risk of fetal harm.
Okay, crucial point.
Second, it has unique effects on the central nervous system. It can cause hallucinations and, importantly, visual disturbances like photophobia, sensitivity to light.
Visual disturbances, wow.
Yes, so patients need to be warned about potential changes in their vision and specifically advised against driving at night. That's a key teaching point.
Definitely. Okay, before we get fully into nursing, let's quickly cover two others with specific admin needs. Nystatin, a polyene used topically for thrush or vaginal candidiasis.
Right. Nystatin isn't given AVS. For oral thrush, how it's used is key. If it's the suspension, the patient needs to swish it around thoroughly, hold it in their mouth as long as they can to maximize contact, then swallow.
So not just a quick gargle.
No, really coat the mouth. If it's a lozenge or troche, it has to dissolve slowly. Absolutely no chewing or swallowing it whole.
Got it. And terbinafine, that's an allylamine, often used orally for nail fungus on mycoses.
Yes, and nail fungus takes a long time to treat. Therapy can be up to 12 weeks for toenails. The big issue with oral terbinafine is the liver.
Metabolism issues.
Heavy liver metabolism. So it's contraindicated in patients with chronic or active liver disease. That immediately tells you baseline liver function tests are essential before starting.
Okay, and that mention of metabolism brings us right back to that huge systemic risk we flagged earlier, drug interactions through the P450 system.
This is a constant battle in pharmacology. Antifungals, especially the azoles, are potent inhibitors of the cytochrome P450 enzyme system in the liver.
And that system breaks down tons of other common drugs.
Exactly. So if the azole is hogging or inhibiting that enzyme system, other drugs the patient is taking, things like certain benzodiazepines for anxiety, some calcium channel blockers for blood pressure, oral anticoagulants like warfarin, they don't get metabolized properly.
Meaning their levels build up in the body.
Yes, potentially reaching toxic levels. So the antifungal could dramatically increase sedation from a benzo, or worse, significantly increase the risk of bleeding from an anticoagulant.
It's like a traffic jam in the liver.
That's a good way to put it. It creates a bottleneck. Clinicians have to be vigilant about checking for interacting medications, especially when using P450 inhibitors like the azoles.
Okay, this is all crucial background. Now, let's put it into practice. The nursing process, starting with assessment before therapy even begins. What are the absolute must-dos?
Knowing the big risks are kidney and liver damage, nephrotoxicity, and hepatotoxicity, the top priority, besides baseline vital signs and weight, is getting those renal and hepatic function studies. BUN, creatinine, liver enzymes, AST, ALT.
Baseline labs are key.
Essential. Also, check hemoglobin, hematocrit, maybe a CBC, because some antifungals can suppress bone marrow function, and obviously identify contraindications like liver disease for terbinafine or maybe severe heart problems for itraconazole, another azole.
Right. Then, during therapy implementation, let's focus on amphotericin B safety again, that IV administration.
High-intensity monitoring is required. For IV ampho-B and also caspofungin, you absolutely need an inline filter. The amphotericin solution itself must be clear, no cloudiness, and always use an infusion pump for control.
And the vital signs.
Critically important. Monitor vital signs every 15 minutes during the ampho-B infusion. That frequent check is how you catch infusion reactions, early dysrhythmias, sudden fever spike, chills, drop in blood pressure. Allows for immediate action.
Makes sense. And keeping tabs on the kidneys.
Constant vigilance. Strict intake and output monitoring, INO, is mandatory. You're watching for a decreased urine output, say, less than 240 milliliters over 8 hours, or maybe less than 0.5 milliliter per kilogram per hour. Report that immediately.
And weight.
Yes. Sudden weight gain is a red flag. If a patient gains 2 pounds or more in 24 hours, or maybe 5 pounds in a week, that often signals fluid retention because the kidneys are struggling. Needs prompt medical attention.
Okay. We covered nystatin teaching swish, hold, dissolve slowly. What about key teaching points for voriconazole and fluconazole again?
For voriconazole, reinforce that photosensitivity warning. Sunglasses, avoid bright light, and definitely no night driving. Remind them to take it 1 hour before or 1 hour after meals.
Okay.
For both voriconazole and fluconazole, because of the fetal harm risk, women of childbearing age must use an effective alternative method of contraception during therapy.
Crucial counseling point.
Absolutely. And for pretty much all systemic antifungals, teach patients the signs of liver toxicity, jaundice, yellow skin or eyes, dark urine, pale or clay-colored stools. Tell them to report those symptoms right away.
Right. Finally, evaluation. How do we know the treatment's working, and how do we keep monitoring for safety long-term?
Evaluation is twofold. You look for therapeutic effects. Are the symptoms resolving? Is their energy improving? Are vital signs normalizing? Are mucous membranes clearing up if that was the issue?
Seeing improvement.
And simultaneously, you're constantly monitoring for adverse effects, especially signs of organ toxicity. Keep checking those lab values for kidney and liver function. Look for clinical signs too. Excessive bruising could mean platelet issues from bone marrow effects. Swelling could indicate fluid balance problems.
Got it. So let's try to summarize the big picture here. We've got these 4 distinct ways antifungals work. Poking holes in membranes like polyenes, blocking ergosterol production like azoles, hitting the unique cell wall like echinocandins, and messing with DNA like flucytosine.
That's a good recap of the mechanisms.
And the 2 massive patient safety takeaways seem to be: number 1, the intense pre-medication and monitoring needed for amphotericin B because of its severe infusion reactions.
Definitely.
And number 2, the constant need to watch for drug interactions, mostly driven by the azoles messing with that cytochrome P450 system.
Exactly right. Those are probably the highest yield safety concerns across the board.
So thinking ahead, you mentioned flucytosine works because we lack the enzyme to activate it. That seems like a perfect selective mechanism.
It is, currently. But fungi are incredibly adaptable. They are eukaryotes, remember? So the provocative thought is, how long until some fungi evolve resistance by, say, losing or changing that specific enzyme, cytosine demonase? It pushes drug developers constantly. The challenge is to keep finding targets like the glucans in the cell wall, things that are absolutely unique to the fungus, giving us the best chance at selective toxicity while these organisms continue to evolve defenses.
How fast can our science keep up with their evolution? That's definitely something to think about. This has been incredibly clarifying. Thank you for breaking down such a complex topic.
My pleasure. Glad to walk through it.
And thank you all for joining us for this deep dive. Hopefully you feel better equipped to navigate the world of antifungal therapy. We'll catch you next time.